It's on this. Hello, I'm Michael Ward. I've been with the Cerebral Palsy Clinic at the Weissman Center for over 20 years now. I'm in the Department of Orthopedics and Rehabilitation Medicine. Actually, I'm moving next to the Department of Pediatrics under the umbrella here of the core of the clinical work for children with disability. I'm an associate professor, and my interest has been in looking at people with developmental disabilities and acquired brain injuries, and a holistic form, looking at not only the motor disabilities but also the sensory and cognitive and social integration issues that people face with changes in the brain tissue. So the focus today is on the biggest single group of people with cerebral palsy who've had prematurity and periventricular leukomalacia, and diving down into how broadly this condition of periventricular leukomalacia, and I will help you understand what that means. It's a mouthful. How it affects people through the lifespan. So we want to understand this relationship of prematurity. We'll look at MRIs that demonstrate the periventricular leukomalacia and then how that relates to the diagnosis of CP. I want to discuss how the white matter, periventricular leukomalacia, affects the white matter, and talk about some of the new imaging we have to better understand interconnections of brain tissues. And then I want to discuss these broadly affected systems, motor, sensory, cognitive functions that are challenged by periventricular leukomalacia. But we should start by talking about some basic definitions. The face of cerebral palsy is extremely varied. People have many different manifestations and support needs and abilities. So it has a definition. We'll be a little bit of cycling back during our talks today, but consensus definition of cerebral palsy is that it's really a group of disorders. It's not one thing. It has different causes, it has different manifestations, but it's a group of disorders of movement and posture. It's non-progressive. We had a little mention here of degenerative diseases, which are not cerebral palsy, and it's something that happens to a fetal or an infant brain. So it starts with a change in the brain very early in life. The part I want to focus on today is this lower section, though, that the definition of cerebral palsy includes co-occurring problems with sensation, perception, communication, and/or behavior, and/or seizure disorder. But it's a very broadly manifesting condition. It is defined by having a motor component, but that's only one piece, and I really want to talk a lot about the other pieces. So I'm going to start with talking about this condition, periventricular leukomalacia. Cerebral palsy is always caused by some abnormality in the brain, and the PVL is the largest single contributor to these challenges. It's the most common abnormality to the brain. It's really complex to understand and explain the mechanism of why periventricular leukomalacia occurs, but the newborn brain in children that are premature, weigh a couple of pounds, is very vulnerable in certain areas. So certain pieces of the brain can fall under a cascade of unfortunate events that can cause substantial brain damage. So it's strongly associated with the prematurity and the low birth weight because the brain isn't ready to thrive outside of the womb at that time. So the other concept here, periventricular, refers to these structures of the brain called ventricles. And so these are located in the center of each hemisphere. This picture shows the brain, the eyes would be down here looking forward. This one has the outline of the skull. But these fluid channels where the cerebrospinal fluid flows, it's sort of like, I was just trying to think of an analogy, but I live under an area where there's immense underground rivers. You know, we have this elaborate storm sewer system that's inside there. You never see it, but it's huge and it's flowing all of the time. So we have this kind of a system which does some drainage for the brain tissues deep inside our brain. And the spinal fluid's made in the inside the brain, and then it circulates around the brain. It floats our brain, protects our brain, cleans our brain. And then that fluid flows down the spinal cord. If you have a spinal tap, they're taking a sample of the cerebrospinal fluid. But inside the brain, the cerebrospinal fluid lives in these oddly shaped internal structures deep inside each half of the brain. Those are the ventricles. So the definition of cerebral palsy is that around the ventricles, in this deep tissue of the brain, there's white matter thinning, leukomalacia. So the leuco refers to the white matter. The gray matter is when you look at a brain, it's the curly gyri that you see. That's the gray matter. Inside of that, interconnecting the surface of the brain to everything else, is the white matter. So the white matter's thinner. So thinning of the white matter, particularly in the area around the ventricles, periventricular leukomalacia. From here on, we'll call that PVL. Okay. I like to do talks with long words. I had to do one once on ventilator dependency and spinal epiphyseal dysplasia congenita, which is, but forever in my life, that just rolls off my tongue. It was like a 5-minute presentation, so you got to be able to say it quick. This is a picture of periventricular leukomalacia. So here's a normal brain, and when the white matter thins, well, first you see there's a large increase in this blackened area. That blacker area is the cerebrospinal fluid. So on your left, you see the brain, which has smaller black areas. You see the black areas surround the brain, and then they're in these deep channels, the ventricles, which we're talking about. So when the white matter thins, then something has to take up that space. So the ventricles become larger, and they change shape. So we see this, kind of scalloped shape. And if we can look, here's the best example, I think. If you look here at this little bridge, this is a bridge between the right and the left hemisphere. This corpus callosum is a deep connections of massive numbers of fibers that connect what's going on in the left brain with the right brain. It's very important. When you look at the brain with PVL, you see this is much, much smaller because the white matter's been reduced. It's thinner. So there's much less interconnection there to travel between the left and the right brain. So the PVL is going to affect deep brain connections. Yeah. The other thing in the PVL is you can look at just that this is the white matter, all of these structures, that it has a different density, and it's not like a little thing. It's not a spot. It's very widespread. We see little fingers of the thinning of the white matter spreading out into all parts of the brain. It's wispy, right? So it's not contained, it's broad spread. And I'm going to point out one more thing. It's in the front, and it's in the middle, and it's in the back, okay? It involves the whole brain. And so that's an important point. So we look at people with cerebral palsy, and everybody got a scan. We would see that big chartreuse area is the number who have periventricular leukomalacia. It's by far the largest brain condition underlying cerebral palsy. The second largest is that yellow spot on the bottom, which is they don't have a abnormality. And periventricular is the largest contributor to these various other things. Different things can happen to developing brains that are like strokes or other conditions, developmental malformations. But PVL, we're going to focus on PVL today. So this may not apply to other etiologies. So next I wanted to talk about the relationship between the surface of the brain and this interconnection process, right? So this is a little map of the brain. The one on the left is looking over to the left. The eyes would be just under the brain. And that red part is the motor strip. That houses it's the precentral gyrus, we call that. But it carries the information which comes out of the brain, goes down to the arms and legs, and really helps to generate patterns of movement. Right? So the primary purpose of that red area is to activate arms, legs, and face. And we can map that out. The surface of the brain was mapped out a long time ago, and the fibers from different body parts are located in different regions. We call it the homunculus. So you see the leg is kind of hanging over in the middle. That's the middle of the brain there where the fibers to the leg go. And then the hand is kind of on the upper outside, and then the bottom part is the face, the lips and the tongue. The representation of the homunculus relates to how complicated is that movement, right? So the leg is the strongest and the biggest, but it doesn't have a big representation in the brain because it's not nearly as complicated as what we do with the hand. So something like handwriting is, this is what I was looking for. So that's handwriting is a lot more complex than walking if you really look at the number of neurons that you need. And what gets the most space, it's like the face, our expression, our communication, this rapid articulation to say spinal epiphyseal dysplasia. That was a lot of neurons to signal that motor output, right? So the face gets this huge representation. So it's, that's the motor homunculus. That's where our motor signals come from. So when we look at cerebral palsy and periventricular leukomalacia, how is that going to affect, our function? And the issue is the PVL is not really affecting the surface of the brain and where all these different individual functions are. This gray matter where the voluntary motor movement is relatively untouched by periventricular leukomalacia. Okay? But what is affected is this interconnection of the brain, these interconnecting networks. And there's been a lot of progress in getting fantastic imaging of these interconnections. Look at that, right? This is a connectome. This is now imaging. It's diffuser tensor imaging, where we can look at the tracks that connect one part of the brain to the other. And so this is a whole brain image, and they add these, it looks like something you would have seen on Thursday, with a Halloween wig, right? But and this picture doesn't mean a lot more to me. That it's a similar interpretation. I can't interpret these tracks, but we do have a way of looking at this issue of how the brain's connected to itself in a much more detailed way. And so we'll talk a little bit about tracks. So these colors represent groups of neurons that are carrying functions through the brain and relating one piece of the surface of the brain to another piece of the surface of the brain, right? This is a critical issue with periventricular leukomalacia. Okay. So we're going to talk about how these connections, then, the periventricular leukomalacia, affect functions in certain ways. So if we look at that motor strip, wrong device. The leg is over here hanging in the middle, and the face is way over on the side. So when these fibers have to come down, to come out to reach the spinal cord and make movement, those leg fibers are in a less optimal place as far as the periventricular area. They have to go closer to the ventricles. The stuff on the outside, the face, has a different little route, and it's not going to need to run through the ventricular area as intensely. So there's more interruption of the information out from the leg area than there is from the face area. And we see in cerebral palsy relatively less challenge with communication skills in people with periventricular leukomalacia. So it disrupts the connections under the motor area more profoundly because of this more central location. So the leg fibers are running right into that periventricular area more often than the arm fibers. This is a picture of somebody upright. They're looking forward. This little MRI, it's a different view. So we're looking at them from behind. So spastic diplegia is a more frequent pattern associated with periventricular leukomalacia. Diplegia is involvement of the legs, that the legs have more motor impairment than the arms. So if we're looking at a modern population where we have excellent prenatal care and many very small babies survive, we see the manifestations of diplegia fairly commonly, right? But it's not that simple, because periventricular leukomalacia also underlies other patterns. So if the periventricular leukomalacia is really broad, it's going to catch all of the fibers. So the hands will have a lot of impairment also, as will even the voice and the articulation and the posture. So PVL is also the most common underlying brain abnormality for people with arm and leg involvement, quadriplegia, 4 pieces. And the PVL that can be very asymmetric. So there can be a whole load of PVL on the left side, and by chance, the right side of the brain doesn't have as much. So that person would have more of a hemiplegic pattern. And then you can get every combination. You can have very asymmetric PVL where the legs are really involved on both sides, but only the left arm. And so you can have every variation of these combinations of body parts, all related to PVL. Just really, the only thing that doesn't happen is sparing of the legs. But here's the most important point I want to make today. So we discussed cerebral palsy in terms of the motor disability. We see the motor disability early, we start early treatment. But the rest of the manifestation of the PVL is very late to emerge. But it in no way is limited to this little piece under the motor strip. And in fact, if you look at these MRIs like this one, there's a lot more concern in the bottom part, which is back toward vision, the sensory part of the brain, right? The part in the front is a little less affected. So the PVL is everywhere in this MRI. And if the PVL, for example, involves a lot of the tissue more in the front, if we looked at this area and we have these big tracts, this massive long tracts, you can see that they go long distances to pull the brain together. This is the area which organizes the human being, and the manifestation really common in PVL is attention deficit disorder. People have difficulties with concentration, organization. So another big manifestation of PVL, independent of the motor, is ADD, which is common among people with prematurity. And you could have the ADD without the CP, or you could have it concurrent with the CP, which is what we are dealing with frequently in the CP clinic. And if the tissue's in the back, as it frequently, abnormal tissues in the back, as we see all the time, just looking at these scans over decades, it's just, you get to appreciate that the motor system may actually be less often involved. We haven't been doing good measurements of that fact, but by just scanning these scans over the years, that there's very often fairly profound PVL underlying the sensory areas of the brain. And I'm going to talk, and if we look at people with cerebral palsy, do they have sensory problems? Hearing loss, a little less involved, but visual impairments and kind of body sense, tactile impairments, extremely common. They're the generally people with CP do have visual and body sense impairments. So visual perceptual skill development and sensory processing frequently very different for people with cerebral palsy. So I'm going to talk about something here. What's this? A little ball. So there's a massive stream. This is the ventral stream that comes from the area of your brain where you have vision down to the area where you store the words, where you recognize what things are, the knowing. It's the ventral stream, right? As an example of just something that's massively connected, right? Your eyes to your language area. And then I'm going to try to toss, good catch. Notice that Mary from OT, that's our team from the CP, is not shouting, it's a ball, it's a ball. As it comes to her, the hands move. And there's a completely separate from knowing, there's a whole set of interconnections that align your hands, not only the object's coming, you know how fast it's coming, you know how big it is, and your whole body prepares with this other piece of interconnections, another massive system. These are showing these interconnection webs, right? There's the dorsal stream, so she was thinking about what it was, but ventral stream, coming up to the dorsal stream, which gets your body prepared to do the motor activity, right? And so there are people that could catch the ball and use the ball, throw it, but can't name what it is, and there might be another group of people that damage the ventral stream that can't tell you what it is, they can't find the word, but they could use it, right? So a lot of these interconnections are independent of one another. It's not an all or nothing. It's which piece of the interconnection is of higher quality than the other. Very complicated, but I think those dorsal and ventral streams help to really illustrate some of the issues related to connectivity. Of these, under the deep brain connection areas of the white matter, the language system has been studied most intensively. There are a lot of nice pictures about the connection between Wernicke's area sensory speech and Broca's area motor speech. And in people with CP, we really essentially never see people with aphasia, like you would see with somebody to damage of one of these areas from a stroke. And these language-dominant areas are involving shorter connection tracks, is the point I was trying to illustrate. So the connection, for example, between these two huge language areas is relatively short, compact, and little. And it doesn't dive down toward the ventricle. It stays closer to the surface. So we see with periventricular leukomalacia very little interruption of speech, of communication skills, of fluency. If that area is damaged also in a developing brain, this is a whole nother talk, but it moves to the other side. So there's a second reason why we hardly ever see aphasia kind of things with children with CP. But so the left brain, or the language dominant side of the brain, tends to use shorter, less volume in these white tracks, so less affected by the PVL. So the right brain and the left brain have different patterns of connectivity. And what we find is that the PVL much more profoundly injures the functional requirements of the right brain than of the left brain. So the left brain is relatively spared the language functions, but the important functions of the right brain are particularly vulnerable. So these functions of the right brain are these integrative, right, deductive, organizing features of the brain. They process a very complex visual and spatial material, and these areas, particularly the parietal lobe highlighted in that picture, are extremely dependent on the white matter. In fact, they're defined by white matter, essentially. So the right brain has a lot more challenge. And it's a hard area to understand. Why do I have a right parietal lobe? What is even that for? Because it's hard to map out. It doesn't map like so nice, like listening is here and speech is there. It's a very integrated system. But some of the things that we see with challenges in the parietal lobe, like where's my body? Like how is my my arm, my posture related to the floor, to gravity? How do my clothes feel on my body? Am I paying attention to that or not? Where's your body in relationship to that seat that you're using, right? How is my body related to what I'm seeing? How will I get through the door and negotiate space? What's my relationship? It's all about these relationships, right? Your body, your chair, but also like, why are we here? Why do we care to, gather together and relate to each other to learn about cerebral palsy? Yeah. And how is my behavior, like coming here, related to my core values? How are we related to each other? Not just physically, but also psychologically and emotionally. So pulling the pieces all together. So, what are possible manifestations of loss of this parietal connectivity? These sensory, you can kind of pick this up from what I'm talking about, sensory processing. We all know the challenges of young people with sensory processing disorders. Clumsiness, social awkwardness, right? If you have a lot to say, but you don't know when to put it in the conversation. So maybe a good vocabulary, but challenges with how to use my vocabulary for effective communication. And this population of people who have a lot of difficulties can feel very disorganized and overwhelmed, have tremendous anxiety and other emotional problems. The next speaker is going to be more detailed in talking about these more psychological components. Right? So these perceptions are really important for daily life function, but they're hard to measure. And essentially in a 2-year-old, we don't have anything to measure. Right? As children get older, as a routine in the cerebral palsy clinic, we will look at people's ability to use complex vision and determine, which of these match. But you need to be a little older before you can start to really get down in assessments that give us information. So we start in the CP clinic with, 7-year-olds. We could start getting this information, much richer by 8 and 9. And as the children get older, we would send them to Dr. Mission, and we get more detailed neuropsychometric assessment to understand in greater detail the effects of this congenital lesion, right, on how your cognition is developing as a whole. I'm going to make another last point in summary about. So we talked about how complicated these issues are, right? And how the manifestations are different. And if we look at children with diplegia who had problems there with the motor strip, the precentral gyrus, they're all going to get treatment. We're going to see the ankle tightness, and we'll do maybe Botox treatments or a brace and send the child to physical therapy. We have universal health care coverage for this population of people, right? If it's in the front and we have ADD, there are pills for that, whether or not you should take them is complex. I talked a little bit about the disorganizing back here, and it's hard to tell sometimes in children with CP on whether the focus problem is more on I'm so disorganized or I have such weak attention. So that's, again, a neuropsychology point to sort out, right? But we have treatment, and, most people come around to talking about treatment, at least for children with poor attention, right? It's noticeable. Then we come back, if you had stuff way in the back and had some visual integration problems, that might be noted. Maybe there's a pattern of dyslexia that affects school achievement. It's not so hit you in the face. It's not so obvious. So the school districts potentially, through vision support services may pick that up and provide support to its student, right? And then we get to this one with the clumsy kid who's socially inappropriate and they're off task. And this one, the primary intervention, this is my little discussion I give with medical students all the time. This one's managed by the principal. Because you're not behaving the way we want, and you're going to get punished for having that disability. So if you look at our service delivery system, and there are treatments for this, it comes in OT, and can you get medical assistants to pay for this service? You can get, probably 100 PT visits for one for sensory processing, right? So there's a discrimination against pieces of the brain, is my point on that. And it just, understanding that periventricular leukomalacia is one thing. It affects the brain from the front to the back, yet we discriminate heavily in medical insurance support as to which section your brain is having the trouble with, right? And we give you less service for one piece over the other. So that was my point. We try to be full service in our clinic and look at all of these pieces together, which is why it's a multidisciplinary clinic, right? If we're only able to look at mechanics of movement, we're going to miss the majority of the issues that need to be addressed for people with CP. So, did I talk too long? Yeah, I thought that was 20 minutes, but it took a little longer. Should we do 5 minutes here, and then any questions that you want to ask about that? I know that's a brain full of information. It feels like this, right? Yes.
I just missed ventral stream connects vision to the lower temporal lobe to recognize
Everything.
everything.
But, we store our words down there too, but it's sort of the whole sense of recognition. That would go, facial recognition goes in there, word, retrieval, finding the word for an object. It's the sense of knowing. I know what that is, right? Using vision to knowing. And vision to doing would be going up toward those sections which pull the body parts together for action, right? So that's a little on the outside of the brain over here. Yeah, I think that's a helpful concept. I mean, it just gives a sense of what these streams, these interconnections are doing. Can we see these on here? Not really. You can see the ventral stream easily. Dorsal stream is not well imaged there. Yeah.
This might be a little bit of a juvenile question, just given.
Not possible. Okay.
But,
Yeah, so, yeah, HI is going to be sort of, well, most of the time the opposite, okay? In that it's going to affect the gray matter much more than the white matter, right? So like as HIE, hypoxic ischemic encephalopathy, is lack of oxygen delivery to the brain cells. And the gray matter cells, they're gigantic. So that type of injury is going to affect the biggest cells the worst. So it's a lot harder on the gray matter than the white matter, right? And it's harder on certain pieces of the gray matter than certain other pieces of the gray matter, right? So it has its own syndrome. But it really is a very different pattern. That would be the contrast pattern, right?
So you mentioned prematurity and low birth weight as precursors or risk factors for
To the PBL.
What else would be a precursor?
You know, some people just have PBL and we didn't know, and it maybe developed when they were in development. They hadn't been born and something happened which was critical at that same stage, like the 7th month, right? So we see that, you know. The other interesting thing, though, is that if you have like a stroke-like event, I'll try to make this brief, and you damage the right hemisphere, you're going to have a lot of the same psychological, spatial problems. But the other interesting thing is you damage the left hemisphere in maybe a second trimester, mid-gestation. Then you damage the language areas. Those language areas pack up. They move over to the right hemisphere, and guess what? The right hemisphere loses again. So the right hemisphere is always the short end of the stick, with right hemisphere damage, left hemisphere damage, with just one hemisphere damage, and PBL, right? It also happens with hydrocephalus and radiation. So these white matter challenges to children with disability are a very large group. So I emphasize there, but yeah. Well, and again, if you know, myself, the CP team, the neuropsychologists, this is our job, is to try to help people differentiate, like, where are you having a problem? Not what is the general problem, but, you know, and try to provide more specific treatment.
How did you get that image of brain?
This one? Yeah, this is called diffuse intensive imaging, but it's, so I don't know the MRI technique that allows them to see this, right? But yeah, do you know the answer on that, DTI? On how you actually get the picture of the tracks?
So it has something to do with word flow or
Yeah.
detecting the word molecule orientation. And these long tracks, if you think about it, they're like lines or tubes. So it forces you more freedom along that directional orientation.
So the MRIs actually pick up water, and because it's magnetic, right? And so if it looks at the contrast between things that are watery and things that are fatty in the brain. There's a lot of fat in the brain. Anyway, that's how they work with the technology to get that, and so they can visualize these strands of nerves. It's pretty cool, though, isn't it? Yeah.
That's artificial color. That's not the real color.
Well, it's not really that color. You notice all the colors were different, right? Like there's bright red. So they pick the color they want for the structure. So it's not really that pretty in there. Are we good?
I think there was one more question there, and that'll be the last question.
It's more of a comment. I feel hearing about the neurodegenerative versus progressive versus kind of static changes. As somebody who lives with somebody who has PBL, I would say that definitely CP is not neurodegenerative, but I wouldn't say that it isn't progressive.
Or changing, the word I say.
Yeah, because life is progressive.
Right. So,
For families to know that some of these processing issues, the principle, taking care of stuff, the vision, you sort of see this come out of the woodwork.
Yeah.
As people grow older, so I wouldn't say it's progressive, but
But-
spasticity has long-term.
point home. Thank you.
Would it be fair then to say that the brain is more or less static in this injury, but the cerebral palsy manifestation is more progressive as the effects of growth and spasticity and other things have
Yeah, because 5-year-olds are not doing algebra. If that's your disability, it's manifest when you're 12. Do you get it? And so it is different for adults. And then the adult world is even that much more complicated when you're responsible for your personal financial management, and that's perhaps not available to you. So again, this is our progression today, is to try to talk more about that. So we have next, oh,